This video is brought to you as part of the Paired Health Mobile Medical Care Educational Series. In this video, Care Coordinator Cathy Holland shares some of her tips and tricks for enrolling patients in the Transitional Care Program upon discharge from the hospital and what she has found to be effective in getting the initial visit scheduled. As hospital discharges can be a complicated process during an already stressful time for the patient, and since the concept of in-home hospital follow-up care is a new concept to many patients, Cathy has developed a set of best practices through her experiences in doing this time and time again. These practices can help lead to a higher conversion rate of patients who were referred into the program and then were able to be contacted and visited in their home after leaving the hospital. Could you start by talking about how you know when a patient is going to be discharged, as you never really know the exact date or time until it happens? So how do you know when they're ready to be scheduled?
Yeah, the case managers put an expected date of discharge in there, which is sometimes ballpark right. With the way they chart, they have to go in every couple of days and put in their system an expected discharge date. And so I look at that, but then also just reading the chart, knowing, looking at their lab values and just being able to clinically see as a clinician that if lab values are trending the wrong way, that they're not going to go home. If the patient's starting to look good, and I see nurses' notes, patient doing well, pain-free. You know, I really read the clinical notes and kind of just get an idea of if I think they're going to go home. I'll call case management. I'll call the nurses station and just speak with the primary nurse or speak with the case managers and ask, is this patient really going home today? What's the ideal? I usually wait for rounds to be completed before I call. I know what time they do rounds at the hospital, so I'll wait. And sometimes they can say, yes, definitely not going home today, and sometimes they'll say they are.
I know that when time allows, you prefer to make rounds in the hospital and introduce the home visit program to the patients face-to-face. Can you explain your process for when you're at the hospital making program introductions to the patients and coordinating with hospital staff?
I'll just go to the hospital and I usually check in with case management, where the case manager on the floor who did the referral, and then I'll just go see the patient or patients, spend some time in the room talking about what is paired health, what do we do, and give them a card with my name and number and their appointment time on it. We set that up. And then I speak with the primary nurse and the case manager and just let them know that we have an appointment scheduled, and if they could please put it on the discharge papers. And you know, just finding that it's easier to explain it face-to-face sometimes than on the phone, but also knowing that when on day of discharge and even in the hospital, patients are overloaded with information. So you know, just that extra contact I think helps instead of on the phone. When they see face-to-face, it helps a little bit processing what we're actually doing.
Can you provide a bit more detail on how you introduce the program to the patient and how you deal with any pushback? For example, when the patient says they don't need anyone to come to their home, but maybe they're not familiar with this type of high-touch transitional care program. Do you have any selling points, for lack of a better term?
So, you know, basically I just tell them about the program, that we work with the hospital to have follow-up care for patients in the area who either don't have a primary care doctor or can't get to the primary care doctor, and the hospital wants the patient to have good follow-up care. And you know, I explain, a lot of people ask about cost, so I explain the you know, if there will be a cost or not a cost. That's one of the questions we get a lot. Most patients I don't really have to sell it to. Most patients are very appreciative that we're going to come to their home and you know, take care of them. We basically explain to them that, you know, it's like having a primary care doctor on call for a short window of time, and they appreciate that aspect of it. Some people, you know, say I don't need it, I have a doctor, and what we try to explain to them is, you know, they may have a cardiologist and they may have an oncologist and they may have you know, their kidney doctor, but we're primary care, so we can manage you know, their primary medical needs, not their specialist needs. And then when we also talk about the other part of our program is finding patients a doctor in the area, they tend to also really appreciate that aspect of it, to be able to you know, get in with a primary care doctor or one of the low copay clinics or something like that in the area.
Are the patient's address and phone number in the EMR ever incorrect?
Yes. That happens a lot. A lot of it is the wrong county, wrong zip code, wrong. So I always verify phone number and address with patients. A lot of times it happens too. What's in the EMR is, say, their home address, but they're going to their mom's to recover, or they're going to their sister's, or we have a lot of patients who are homeless, so they don't have an address. I mean, so there's something in Sorian or the EMR, but they're at a shelter, in a local shelter or something. So I always verify address and phone number with a patient when I schedule them.
Do you find it helpful to schedule patients in time windows like a cable company might do versus giving them a static time?
Yes, we do. One of our providers, I give a large window of time to patients. I say between 10 and 2, and I rarely get pushback on that. Most people say, okay. The other providers that work longer day and more time, I usually give a 2 to 3 hour window, depending on kind of where they are and how many patients are in that area. Most people are okay with a 2 to 3 hour window. They don't have a problem with that. And I usually say, we'll call you if we're running really early or really late, and if not, we'll be there in that 2 hour window. And most people are acceptable to that.
And I guess some patients are okay with a longer window.
Yes, and a lot of people will say to me, I'm not going anywhere, I'm here all day, I just got out of the hospital. And I'll make a note for the provider that says, patient flexible on time, can see, so they know they can move them around a little bit.
What would you say is the most challenging part of the scheduling process?
The most challenging part is getting in touch with patients. They don't answer their phone, or their phone's been disconnected. A lot of it's phone's been disconnected, leave messages and get no call back.
Finally, can you speak a bit about scheduling follow-up visits after the initial visit has happened? The providers are obviously scheduling these in the field when they're with the patient, which makes sense, but how do you coordinate with them on when to schedule the follow-up visits so that you have the flexibility to plug in new patient visits into their schedule as referrals come in?
They also give a window, and then that way I can move follow-ups based on a new patient coming in and where they live, based on the follow-ups, and moving people around a little bit. So they do schedule the follow-ups while they're with the patient, which makes sense to do the next visit. But the initial appointment would be not time beneficial or the best use of time for the mid-level or the doctors to schedule.
Thank you for watching this segment of the Paired Health Mobile Medical Care series. Remember to check out the rest of our series and much more at www.pairedhealth.com.